Hello, everyone. Welcome to SAMBA's January webinar. We're going to be covering a multimodal analgesia review, and that is going to be led by Dr. Peter Amato. This is Ashley Schilling. I'm an associate professor of anesthesiology and orthopedic surgery at the University of Virginia. I'm going to be moderating the webinar tonight. So everybody, welcome. Just to put a plug in for those of you who are not SAMBA members, please consider joining the society as it offers so many benefits to members, including a discount at SAMBA's upcoming annual meeting, which is going to be held in May in Orlando, Florida. Please visit our website, www.sambahq.org, to see the benefits of membership. So before we get started, I just wanted to cover a few quick housekeeping notes. In the upper right side of your computer screen, you will see a control panel. Please note that this webinar is listen-only mode. So if you speak, we will not be able to hear you, but we do encourage you to submit your questions in the chat box. So I will be looking for questions and we'll answer them at the end of the presentation. You can type in a question or comment and submit it at any point during the presentation. And then we'll have time for the question and answer at the end of the presentation. So I want to introduce Dr. Peter Amato. He is an assistant professor of anesthesiology at the University of Virginia. He is the director of the fourth-year anesthesiology clerkship and is heavily invested in resident and medical student education. Dr. Amato specializes in regional anesthesia and ambulatory surgery. Some of his interests include acute pain management, medical education, and medical simulation. So he is quite an expert on multimodal analgesia, and I'm going to turn it over to Dr. Peter Amato, and I'll be back at the end of the presentation. Thanks, you all.
Thanks, Ashley, for that introduction. Today we're going to be talking about all sorts of different analgesics that are relevant to our care in the ambulatory surgery population. So let's get started. So why do we want to do this? We know if we use different analgesics from different classifications, things work better. In the age of ERAS protocols, it would behoove you to become familiar with some of the ideas represented there that we'll sort of go over in a couple of slides in terms of the outcomes of reduced stays, et cetera, that can probably be applicable in the ambulatory population as well. I'm going to review some of the pain pathways relevant to these drugs and how the multimodal analgesics work. And that'll involve major classes of analgesics that we'll review. We're going to talk about some practical things like dosing and side effects and cost, and some evidence for why we're going to use these. So multimodal means many mechanisms together to treat pain. We're going to put these things together and in perhaps smaller doses of each achieve an improved pain control totality, and hopefully do this in the setting of reducing opioid use, which can lead to many side effects. But as you'll see in this presentation, some of these, or many of these other multimodal non-opioid analgesics do have their own side effects that we have to be wary of. This is a recommended practice by our American Society of Anesthesiologists as well. So enhanced recovery after surgery protocols have demonstrated across a number of different surgical subspecialties that there's better outcomes when we protocolize care. We get shorter hospital stays, we get fewer complications, and patients are more satisfied. And this whole process runs the gamut from pre-admission all the way through the postoperative phase. It can involve other things like nutritional support and lifestyle modifications, but where we can make an impact is in the pre through postoperative phase, where multimodal analgesia is pretty huge. Other things that ERAS protocols strive to do is to minimize things that are attached to the patient, optimizing fluid balance so that we don't contribute to edema and things that can slow their recovery as well. So here's where we're going to use most of these items that we're going to talk about today. So let's touch on pain pathways here. So something happens to you, you have a surgical insult in the periphery, and there's an immediate release of modulators of inflammation, prostaglandins, acids, bradykinins, histamine, and that stimulates nociceptors, that many of which have bare prostaglandin receptors, but there's a number of different mechanisms for that to happen. It's transduced through the peripheral nerve to the dorsal horn, where there's interneurons that decussate and then ascend via spinal thalamic tracts to your midbrain and thalamus, where things are eventually perceived in the cortex. But there's also some descending modulatory pathways via serotonergic and noradrenergic pathways that come down and make an effect on sort of modulating that input signal. And these are going to be the focus of some of these drugs today too. So here's where some of those drugs can play a role. Starting with the top, from perception, we know that opioids certainly can do that, but NMDA antagonists, even Tylenol and alpha-2 agonists can have an impact there. Descending modulation pathways are going to be affected by a number of drugs we're going to talk about, specifically anticonvulsants, gabapentinoids, NMDA antagonists. And then alpha-2 agonists also play a role there, as well as in the dorsal horn and maybe in the periphery. And of course, getting down to the actual sites of trauma, we're going to have a lot of NSAID